Okay. Well, we had a really small meeting today. So this is the Prostate Cafe, and we invite any and all questions related to prostate or prostate cancer. If I can't handle it, I'll find out your answer. But anyhow, you'll have more food to eat since you're few. And I want to thank the Dendrion Corporation, who provides the breakfast they have now since we started the cafe. They're really interesting, kind of state of the art. We've been using that type of procedure for a while too. It's a monoclonal antibody. And for patients who are candidates for that, what we do is we take your blood and it gets shipped out to a laboratory where immune enhancing cells are generated and then sent back so that they recognize a person's cancer. It's very specific. So we refer to it as a designer monoclonal antibody. So it's taking it to the next level. And what it also does is once it's reinfused, it teaches the remainder or those other immune cells in your body to then attack the cancer. So it's very interesting. It's typically done in 3 separate sessions. We like to space them by 2 weeks apart. So a treatment course typically takes a month. It's week 1, week 2, and then week 4. But it's been very interesting, and we've got some really promising results. So anyhow, you know, this meeting is new, but the Dattoli Cancer Center was founded in 2021. It's when we opened our doors, and we've done a lot in terms of the technologies that we've advanced here and treated people from all over the country and all over the world. But I do want to introduce one of our very first patients in 2021, and he's gonna tell you about our journey.
Thank you.
Or his journey.
My journey. Yeah, my journey. Good morning, everybody. My name is Stewie Bitterman. I think I'm probably one of Dr. Dattoli's first patients. Dr. Dattoli used to be in Tampa, and it's come down to SMH or Sarasota Memorial Hospital. And I was treated here October, right after 9/11. And interesting story, I'm not going to bore you, but I was diagnosed with a PSA of 4.3 and a Gleason score of 6. And I went to a urologist in town, and I was home after my biopsy, and I got a phone call, and my wife answered the phone. She said, "Stu, get on the phone right now. It's Dr. So-and-so." I'm not going to mention his name because if I saw him, I'd run him over with my car. Only kidding. And I got on the phone and I said, "Good morning, Dr. So-and-so. How did I do?" He said, "You've got cancer." Exactly the way I said it just now. Well, you know, someone says that to you, you don't know whether to know what or go blind. And I said, "Well, what do I have to do?" He says, "You're gonna meet me here at my office on Wednesday at so and so time because I got it." Sorry? Oh, I don't think it's on. Testing. Hey, oh, there we go. There we go. Aha. Here we are. Thank you. Sure. In any case, I met Dr. So-and-so And he assured me that he's going to save my life. And made an appointment with him, with my wife, who was sitting right by me. And we got into the elevator, and I said to her, God, Marcia, I'm so excited. She says, calm down. She says, wait, I don't know. I wasn't crazy about him. There's got to be an alternative to surgery. And the alternative to surgery was on Fruitville Road in Sarasota. And my savior is this guy sitting right over there. And we came here 2 days later, and I tried to make an appointment with Dr. Dattoli. But his staff told me that he had to call me first to see if I was a candidate for seating. 2 days later, my wife and I were sitting having dinner together. We only lived 15, 20 minutes away from here. And it was Dr. Dattoli, who had me on the phone for 45 minutes, convinced me that I should come to the Dattoli Cancer Center, which I did. And had my seating, and was a happy guy. Because from that point on, knock on wood, I never had a problem. My PSA was down at 0, and I'm happy. And it's just whoa.
Sorry, I'm late here.
Yeah, it's okay. It's an amazing place, and I'm here to help anybody who wants help. Not medically, but tell me what your concerns are. Tell me what you would like me to help you with my expertise, and I'm here. Come on, someone has to have a question. I get paid by the questions here. So, you know, nobody's asked me any questions. I'm gonna have to leave here. He's not gonna be happy, and I'm not gonna be happy.
How did you hear about the code?
My wife actually was doing some research and found out that the Dattoli Cancer Center just opened here. And one of her girlfriend's husband was a candidate for prostate cancer, and Dr. Dattoli treated him when Dr. Dattoli was up in Tampa. And he was his wife was a good friend of my wife's, and my wife called her, and she said, Margie, she said, have Stewie make an appointment with Dr. Dattoli. My husband is doing great. So that was one thing. And then one day I was in a supermarket here in Sarasota, and I met a gentleman who was on the board of SMH, Sarasota Memorial Hospital, who I knew. And I said, gee, I said, I can't believe I'm running into you. You wouldn't believe it. I was diagnosed with prostate cancer, and I'm thinking very seriously of going with Dr. Dattoli. What's your feel about him? And he looked at me, put his arm on me, on my shoulder. He said, Stu, I wish that Sarasota Memorial had the machinery and all of the updates that Dr. Dattoli has on Fruitville Road. We are delighted to have him here on our staff. So I figure this guy's on the board of the hospital. He can't be all that bad. And that was convincing me to come here. And I've since had a couple of really interesting stories. I don't mean to bore you, but Michael Dattoli would give my name to prospective patients. And you know, if you have any questions other than medical, call Stu Bitterman. He'll help you. Well, one night, my phone rang, and I hear my wife saying, oh yeah, oh sure, oh you want to speak to Stu? Sure, he's right here. And she said, Stu, there's a gentleman on the phone. He's a pilot for Delta Airlines, and he lives in Bradenton, which is the next town from us here. And he wants to speak to you. So I got on the phone with him. We spoke for a half hour. Had a lot in common, talking about prostate cancer and talked about his career with Delta Airlines. And long story short, came here, he had his seating, he's healthy as an ox. And that's part of the story. 3 years after he was treated with Dr. Dattoli, my wife and I went on a trip to Italy. We get on a Delta Airlines flight, and the captain says, "This is your captain speaking. We'll be flying at 35,000 feet, blah, blah, blah." And my wife gives me a nudge. She says, "Stewie, that's Captain Mosher. You spoke to him. That's one of Dr. Dattoli's patients." I said, "Oh, yeah." So I took a little business card out. I wrote on, "Dear Captain, when you get a chance, I'd like to say hello to you." I just signed my name. We were in business class on that trip, so it was kind of like a small area. And the captain came out of his cockpit and walks over to me and says to me, "Stu," and I of course, I never met him. I just spoke to him that one or two times. And he said to me, "Stu," he said, "you saved my life." He told everybody in business class, he says, "This gentleman saved my life. If it wasn't for him, I wouldn't be flying a plane today. But because I had the seating as opposed to the actual operation, I'm now flying." And the guy was as happy as a lark. That makes you feel like 100%. And over the years, over the 20 some odd years that I've been with Dr. Dattoli, as a patient and as a friend, I've helped many, many people, and it just makes me feel good. Now, where are you in the procedure right now?
I'm on my 9th treatment already of the external beam.
Right.
Switch to first.
Everything good?
Yep, all good.
All good?
Yep. Hormone therapy and some of the other things.
Right. And I know you're starting on tomorrow, right?
Monday.
Monday morning.
11 o'clock.
What time?
11.
11 o'clock. That's the best time to get it done.
Today was 22, so I had my midway at 20, and my shrinkage was 30% in the first 20, after the 20 treatments, and of course the hormones and all the medications. But I was very pleased with that number.
Wow. And no effects, no after.
Well, I mean, it's just, since I started the treatment, 22 days ago, at the midpoint, you get another measuring, and 30%, shrinkage, to meet that. So I knew that the doctor that was in there said yes, the same thing. My biggest thing with the side effects was the hormones, the medicines. So my nurse, actually, she switched it up a little bit, and I feel a lot better.
Good.
Yeah, the first 10 days, I was like, oh boy. But we just had to tweak them, and now, yeah.
That's great.
Yeah, thank you.
Stay well.
Thank you, sir. You too.
So I was wondering, so did you just have the seating? They didn't do the external beam at that time?
No, I did the extra.
Oh, okay, you did
Yeah,
that too. And
yeah,
you
sure.
you went through the whole.
Yeah, the external beam.
Okay.
And I had the seating. Then after the seating, I think I had 4 or 5 other.
Sort of everything.
Yeah.
Okay, yeah, okay.
It's been great. Dr. Dattoli has a phenomenal reputation. Not only in town, but in the world.
Yeah.
There's a couple of people, as you can see, signed on on our wall here. And you know what? I still can't figure out where my signature. I can't figure it out. I can't figure it out. That's one unbelievable wall of fame. Anybody else?
All right. Well, thank you very much, Stu.
Thank you. Yeah.
Thank you.
All right.
Sorry.
The interesting thing is about that shrinkage, it'll even go lower.
Oh, yeah.
And interestingly, it's not something that's gonna go lower and then pop up back again. It's gonna stay through your lifetime. It'll remain low. You know, I know that because I've treated patients and followed them for so long. So it ends up being a real big plus advantage. But yeah, the hormones can be miserable, but they are a necessary evil in certain cases, just the nature of what we do here. Are there any other questions? I have topics we could talk about.
I have,
Yeah.
I'm curious, questions about the seating, the process, what to expect. I mean, the pre-operative, could you maybe just touch on that real quick?
Sure. Well, first of all, prior to the seating, typically the day before, we inject a Stasor. It's a hydrogel, and it actually inflates the area between the rectum and the prostate. Now, the reason I do that then is twofold. Number one, because someone would ask, why don't you do that before the DART radiation? And the reason is, well, with the DART radiation, we're really, really precise, and we go out of our way to avoid the rectum. It's not so common that any man has bowel symptoms. And with radiation, the most classic bowel symptom is diarrhea, but we don't see that a lot. It's possible, and sometimes it's from other medications that we give, but if anything, constipation. But having said that, we're really precise, but at the time of seeding, now understand your prostate lies right on the rectum, okay, and that we can't avoid, okay, and while seeds are extremely precise in terms of what they do and how the dose they emanate, it's right next to the rectum. So that rectal wall then will get a higher dose. Not really high, but it'll get a higher dose that could cause some bowel issues. So that's why we do it then. And so again, we do it then because the seed implant may last 3 months, okay, up to 6 months, and we want it to be buffered that entire time. The hydrogel, though, you pee it out after 2 to 3 months. So if we did it up front before the DART, well, by the time we get the brachytherapy, the seed implantation, it's already dissolved. So it doesn't do you any benefit. And that's why we do it in that way. And those men who have other reasons, or we're just doing DART alone, then we do it right up front for the DART. So.
And then the next morning.
So moving on. So the next, you will have to pass a preoperative test, with EKG and some blood tests. The actual procedure, though, is done right now. It's done in an operating room at SMH, where I've had that for over 20 years. And soon, though, we're going to be relocating. You may have heard that. I don't know if anyone's heard of it. We're going to be relocating to a center, which is right here on Tuttle. So, it'll be very convenient for you all and for me, because you'll be able to go out of our parking lot up Tuttle and into that parking lot without having to make anything but a right turn. So anyhow, but the next day, the time of the seating, we get you on a gurney, the operative table, and then we do provide anesthesia. There's a formal anesthesiologist there, and depending on the patient, they make the best judgment in terms of what kind of anesthesia you should have, and it can range from anything from an epidural, which is kind of a spinal anesthetic, which is a local block, to something called LMA, which is a hybrid version of anesthesia, general anesthesia, but it's easier on you. And general anesthesia, we just don't do that anymore. And so it's between those two. The procedure is done. It's quick, fast, easy. There's no cutting. There are no incisions. And so we use these tiny needles to inject the pellets into the prostate itself, and while looking at our 3D colored upper ultrasound, and we try to match it up to your pre-evaluation. So when you first come in here, you all get a 3D Doppler ultrasound, and we download that image, and we also download the midpoint, which you were referring to, and we then look at that from the perspective of, okay, maybe we should put a higher dose, selectively where your tumors began, and that's what we do. A long time ago, I even developed a procedure, and I published on it, where I actually put seeds just outside the prostate. And it's interesting, I'll show you that. So the prostate is an organ that looks something like this. And if there's a tumor here, well, and again, this is your groin area. Okay, and we're coming up with our needles through the perineum. You can all see this. So in essence, what I try to do, and Dr. Soni does as well, is recognize that this area here, well, this is a tumor. So I'm gonna make that hot like that with the seeds. The seeds are really tiny. But then you say, okay, I've covered it all the way around here. What about there? Because most prostate cancers begin on the edge. It's called a peripheral zone. And so they begin on this edge here. And so then the question is, well, what can you do about that? And what you can do is actually put seeds like that.
On the
Now-
outside of it.
What's that?
On the outside.
On the outside of it. Yeah, so we're putting seeds on the outside of it. Interestingly, I published this first in a journal, I think it was 2002, a long time ago. And I published it, I spoke about it extensively, and what happened was I got a lot of calls, and the doctors told me, wait a minute, we're doing this, but the seeds are going all over the place. And I said, really? I don't have that experience. Well, as it turns out, the reason I didn't is the seed that we were using. So if you take one of those seeds and blow it up, 10,000 times, most seeds are like this, where they have what we call convex ends, like bullets. And what happens if you put a bullet there, well, yeah, it can actually meander away. So what I do now is I don't use a seed like that, but rather a seed that has concave ends.
Oh,
And I have a small tool that I put right up like this and spin the channel. And by doing that, this gets locked right in. So the seeds never go, but they stay exactly where I put them. And so, yeah, so that was the answer to that. So based on that, we use seeds that are concave. So the seed implant is then done, and you go off to the recovery room where you stay a varying period of time. As soon as your vitals are normal, and they should be, they'll watch it for maybe 15 minutes to half an hour, and then you go to a room where you go, it's called outpatient observation. So you're basically an outpatient. The problem is, the hospital wants to keep patients in a little longer, and which is fine because you're being monitored by a nurse or nurses. But we look forward to just doing it in an outpatient center, because what will happen is you'll have the procedure done, and right after the procedure, you just come right here and meet with my nurses here. So it'll just be a little more convenient. But it's been tried and true at the hospital, and I've always done it in a hospital setting, because this room right here was supposed to have been a surgical suite. And we have all the plans to do that, but I was just so accustomed to doing it at a hospital, and I just want to continue to do it at a hospital. But surgical center will be like the hospital, since they can also they will keep a patient up to 8 to 10 hours, or they can even keep you overnight if they had to. So it's very well monitored as well. So that's how it goes. You come back here typically the morning after, and you get a series of scans, because I just want to make sure everything is positioned right. I want to make sure there's no problems from the surgical event. And that's what we do. And then you're discharged. You can go. All right. And probably for the first couple days, you take it easy. Most common symptom after brachytherapy, if you have symptoms, would be a little burning with urination. You could have a little blood in the urine, but it's not so bad. Yes.
I'd like to add one comment to that,
Yeah, sure.
if I may. I was admitted to SMH on a Thursday. No, I'm sorry, on a Wednesday, and had seating done on Thursday. And I left the hospital on Thursday afternoon, and I raced a sailboat on Saturday morning.
Yeah.
Sorry?
You didn't take his advice.
I mean, I just felt great. It was a small sailboat.
We don't impose any strict, certain restrictions on you.
No.
What I typically say is do as you feel. And so for some people, it's sailboating the very next day and motorcycling or whatever they typically do. Other people, they just want to take it easy. one of the problems again with the hospital is that it's a hospital. So while you keep you there, they just bug the heck out of you and you don't get any sleep.
It's all because of the downs.
Yeah, problem.
Oh, wow.
Never get out of it.
They're not gonna make any money if they don't stay over.
That's right. Yes.
Okay.
Yes.
On the seating, so you aren't putting the seats all throughout the prostate, only where you think or identified where there were tumors?
Right. So the tumors are going to get the highest dose level. There's going to be areas, for example, the prostate has the prostate urethra going right down the center. And that's the tube that you pee through. So that is very sensitive to radiation. So we really go out of our way to avoid that. Okay. And also, I do something called a peripheral seed loading. There are different types of kinds of ways you can do seeding. And again, one of the more standard ways of doing seeding is called uniform seeding. Okay, and what that basically means is pay no attention to where the tumors are. I don't do it this way. Okay, and just uniformly put seeds. Each seed is equidistant from the other seeds. So it kind of looks like this. And it looks really nice, it looks nice and uniform to do it that way. But when I first evaluated this way, if you just think about this, if these were little heaters, okay, well, you got all these heaters going on. Well, the center is getting the heaters from every which way, all the way around it, okay? It gets hot, okay? Whereas the outskirts, and as I say, most cancers begin in the outskirts, in the periphery of the prostate, would get a lesser dose. So when I first did evaluation of this, and I published on this, the center gets 10 to 16 times the dose as the outskirts. Yeah, and so it didn't make any sense. And so the way I do it is completely different. And basically, if wherever there's a tumor, those areas are going to get a higher dose. So that's where you're going to find most of your seeds coalescing around the tumor. And it doesn't look that pretty, okay, but it's effective. And on the outskirts, there still could be tumors beginning here, 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 or even here in the center. But the center is always going to get enough dose. And so what I try to do is a non-uniform seed pattern, because we have to also respect the fact that there could be microscopic disease that's not picked up by whatever imaging we've done, be it an MRI or 3D colored or ultrasound. So, there'll be seeds staggered in different locations, never in the urethra, though, or never really near the urethra. So it's called urethral sparing peripheral seed loading. Okay, and that's the style that you'll get here. And there were two schools of thought with brachytherapy, and one was here, let me say East Coast. I had a lot to do with the development of it at Memorial Sloan Kettering Cancer Center in New York City, and that became the New York style, and then the other style was actually Seattle, Washington. And Seattle, Washington, to this day, they did the uniform seeds, and they still do it that way. I've never done them that way. I do the peripheral seeds, and I think it just works out a lot better. It certainly does from the standpoint of side effects. All right. And we do have instruments. So, also many places doing brachytherapy, they don't know exactly where the tumors are like we do. Because we do have these special instruments, the 3D colored Doppler ultrasounds, and we have a lot of experience with it. They're very rare machines. I probably told you guys we have 3. And there's one in Los Angeles, there's one in New York, and there's one in Munich, Germany. That's it. We all know each other and talk to each other frequently. So that's the way that is. All right.
Thank you.
Are there any other questions? Okay. An interesting topic, and probably for all of you, would be, what about diet, and nutritional fortification and supplementation? I do think it's important, and prostate cancer, it's especially important because most studies that look at cancer and diets, there are some generalities that they make, but there's not so many specifics. But with prostate cancer, there's actually specifics. And there are certain agents which actually retard prostate cancers, sets them kind of back or slows their growth. And one supplement is called lycopene, and that's an agent that's in primarily red fruits. So you'll find them in red tomatoes, but especially in cooked tomatoes. It comes out really heavily in cooked tomatoes, sauces. There are some red peppers, and there's watermelon has a high content of lycopene. So that's an important one. And there are studies demonstrating that it actually retards prostate cancer growth. The other is vitamin D3. And that's interesting because I first learned about vitamin D3 and its relationship to prostate cancer about 17 years ago. And what I did is I subjected all of my patients, I had thousands, to vitamin D3 because we found it to be important. But interestingly, what I came to find is that the vast majority of my patients, prostate cancer patients, had low vitamin D3s. It was like a deficiency. And interestingly, and that was in contrast to other patients being followed. For example, it was women with breast cancer or men with lung cancer. Their vitamin D3s were low. And if they weren't, if you gave them D3, it would just pop right up. Not with prostate cancer. It's almost like a resistance too. So sometimes you have to take higher doses, at least 5,000 a day, to get the level up. And it does appear to be protective for prostate cancer. But then the other general guidelines within the framework of cancer would be, and it's very similar to cardiovascular health, and that is, and you probably have heard about the Mediterranean diet. It's and there's places around the globe called the blue zones, and there's 6 blue zones, and they all share very similar features. One of which is they're primarily vegans. Well, let me say no. One of them is vegan, but most are by Mediterranean diet, which is fruits and vegetables, and when they do get protein, it's from fish and poultry. Then that seems to be a pretty commonality amongst every single one of those places, the 6 blue zones. And so that's what I recommend with fruits and vegetables and nuts and berries tends to be important. And then the fish seems to be important. And it comes down to different types of saturated fats. So, for example, salmon and mackerel have really good fats from the standpoint of thwarting cancers and improving cardiovascular disease and lowering risks. I often talk about, if you like avocados, it's probably one of the most nutritious foods imaginable. And the other things that with cancers is anti-inflammatory foods, really important antioxidants. It appears that cancers thrive in an acidic and inflamed environment. And that's actually what happens with saturated fats, especially beef and pork. And pork is just as bad as beef, maybe even worse. And that's what it does. It just kind of causes inflammation. There's a test called C-reactive protein. It's a blood test that can be done to look at your body's state, like what's your inflammatory count, and we typically do that. We should be doing it as a preliminary test before coming here or while you're here. It's an important test, but things that reduce inflammation, and that's why I bring up avocados and extra virgin olive oil, powerful anti-inflammatory, antioxidant, and everything else. The fruits and vegetables are also powerful anti-inflammatories. One specific supplement is turmeric, and that has powerful anti-inflammatory, antioxidant properties, and also resveratrol, which is what you find in red wine and dark chocolates. But I would tell people, but you'd have to be a wino to get enough resveratrol. Maybe Stewie.
Father of the day is that.
But so I think diet does matter, and it's interesting because a lot of my patients from a long time ago, they had crappy diets, but they got prostate cancer. It was a wake-up call for them. They started paying attention to me and others, and started pushing themselves away from all those red meats and porks and all the bad foods, processed foods. And they're probably living longer than the population at large. I mean, you'll commonly see men here coming in, in their 90s, and it's very common. And they may have had really bad prostate cancers too. So anyhow, diet is definitely important. See, the other hot button with prostate cancer, and I know you're all beyond that, but you could at least share it with your friends and relatives, and that is the type of biopsies that are done. And the standard, maybe even it's still considered the gold standard in prostate biopsies, is to go through the rectum. And it does access the prostate, and you can get your diagnosis from that, and most of you have had it done that way, unless it was done here. But the inherent problem with those biopsies is that there's a lot of pain receptors in the rectum, and you can't avoid it. It's just, just something that happens. So if you're piercing through the rectum to get to the prostate, each of those piercings, you're hitting the nerves in the rectum, and that tends to hurt not only while you're getting the biopsy, but immediately after. It's painful to get out, and it lasts for a while. And most rectal biopsies, it could take several weeks to actually for everything to calm down from what was stewed up from the biopsy. The other problem is that by going through the rectum, you're advancing bacteria from the rectum into the urinary system. And so if you look at that data, it's interesting because 5 to 8% of the men who have that form of biopsy end up in the ICU with body-wide sepsis. And the other thing is that there can be a little more blood dispersion as a result of transrectal biopsies, and just because the rectum has a lot of vessels associated with it. Prostate does too. So any biopsy, you'll have blood in the urine, but it's not so much the blood in the urine; it's the blood that hit the rectal vessels, which then communicate with the regular circulation of the body. So there's data suggesting that biopsies for the rectum can actually spread prostate cancer. Just like radical prostatectomy has if you can just Google that, it's a number, a real number, and it's not talked about much by urologists, but it's a real number. So in contrast, we do it differently, and it's done with a similar probe. We use our probe, which is Doppler ultrasound, so we're looking right at it. Prior to most biopsies, we'd like to have an MRI. And again, I'd say the gold standard probably in the community is to do an MRI, and then most urologists will say that when they do the biopsies, they fuse it with the MRI, and we do the same. So we use a combination of the MRI fusion with our Doppler ultrasound. So we get, kind of a twofer. It's just a better outcome. And from the standpoint of securing a diagnosis, the first back there's a poster, and it talks specifically about prostate biopsies. And I've published how if we see it with the Doppler ultrasound, just our Doppler ultrasound, and if I say it's cancer, it's 98%. What I did is in these studies, I labeled certain ones, and I said these are going to be cancer, and then see how good I did. I was correct 98% of the time. That was a fairly high probability, and you add MRI to it, and if you have a cancer, we're going to find it. I think the misses, if it doesn't come back cancer, a lot of times what happens is, a tumor is harder than the other part of the prostate, which is softer. And so as the needle comes in, sometimes it moves that like a marble, just kind of moves it away. It moves. And so you end up biopsying not it, but the tissue around it. And I think that's the reason why, there can be, even with urologists too, even with MRI fusions, negative biopsies. So it's not only, sometimes I know you think what you got is just what was biopsied, but sometimes there's things, things that you don't know about. Okay. So that's a hot button, and I've been doing the transperineal biopsies as another way of doing prostate biopsies, and that's going through the area between the anus and the scrotum, and it's soft and it gives direct access to the prostate. And I would argue it has a better chance of getting prostate cancer, especially in larger glands, because sometimes in larger glands going through the rectum, you got to go through the rectum, and you got to go to the other side of the prostate that's large. You just can't get there. Whereas with transperineal, going through that area between the anus and the scrotum, you can get anywhere. And there's less pain sensors as well in that perineal region. So that's prostate biopsies. And again, there may be some papers out there that I've written in the past to journal articles for contributions. Well, you know, we've really advanced our technologies, and you know, when Stewie was treated, what had happened was I was working with a team in New York, and they came up with a newer type of radiation. It was called intensity modulated radiation therapy. And when I learned about that at Sloan Kettering in New York City, I talked to the company, and we got them down here. And I came down here, and we were the first freestanding center in the world to do what was called IMRT. But it's really changed since that period of time. So that was the best available at the time, and it's still good, but there's a lot better now from the standpoint of what we do. And interestingly, you've all had a simulation, and you know, at the beginning of the simulation, we take lots of images of you, and that's what we do. Well, in the past, what would happen is with IMRT, is you take all those images, and it's a data set. So you have all this data about a person, where the prostate is, the bladder, and all the tissues around it, lymph nodes, and so on and so forth. And then you would derive a plan off the data set. Prior to IMRT, you would basically just say, well, this is the area that I'm going to treat. So I'm going to treat the whole area. And that's what was done. It was called three-dimensional conformal radiation. Again, it was the best for its time. But with IMRT, what it did is it took all that data set and it put it into a computer. And the computer would do millions of iterations to try to figure out what is the best plan, where should the beams come in, what angles, so on and so forth. How many microbeams should I have? And that was interesting, and that kind of changed the field, you know, of radiation, because it made it so much more precise and targeting the cancers while avoiding unwanted areas. But what we came to find over time was that the data set that's taken on day 1 cannot necessarily be used for day 5, for day 8, day 11, day 12, because things are moving, things are changing. You know, you may lose weight, you may gain weight, you may have more fluid in your bladder, more air in your rectum. You don't know. And so it's not static. So things aren't staying the same in the same way that they were on day 1. And so for that reason, we do imaging daily with many, many technologies to figure out where is everything right now? How does that work with the plan? There's a lot of ways that we do that. There's an interesting one, which is a digital imaging, which is fantastic. And we use cone beam tomography, but also about 8 or 9 other technologies to figure out exactly where everything is right then and there, so that we know we're hitting our targets. Because if we didn't do that, we would be hitting targets that are supposed to be there, not where they are. And that's really important. It's changed, you know, that back then, again, Stewie may have had some irritative symptoms of the bladder and the rectum. And while you all may still get those, it'll be minimal comparatively, because we're being that much more precise. Okay. Also, you know, I was a big proponent a long time ago. I was one of the founders of prostate brachytherapy, and I was coming out of the rank and file of doing other things like surgery, and with its complications of incontinence and void leakage and just lifelong problems, and of course getting through the surgery itself, which takes 3 to 4 hours, and the recovery, which takes many weeks, and you could end up landing in the ICU again for lots of problems like lymphoceles and blood clots and all kinds of other things. So that when I got away from that, I was on the forefront of brachytherapy. The first thing I thought was that it was the holy grail, that we would never have another better treatment. And for one, we would never have incontinence, and we still don't. Number 2, we could maximally preserve sexual function. But as the time went on, and with the PSA, you know, I start to see that even still, some men's PSAs are rising, and it wasn't an insignificant number. And you just think about that. It has to do with again, the fact that most tumors are on the edge and they have legs. And as good as seeds are, and that was one of the reasons why I wanted to put seeds outside the prostate, as I previously discussed, but it wasn't good enough. Okay, it wasn't good enough to counter these tentacles. Also, those tentacles tend to go in these structures in the pelvis called lymph nodes, and they go all the way up to your neck. And those lymph nodes are commonly involved with cancer. For about 10 years, 10, 11 years, we were involved with a type of test, which was a nanoparticle test, the tiniest imaginable substrate. And boy, it was good. And we really got to understand just how common it was for lymph nodes to be involved with prostate cancer. Even Gleason 6s, it was not uncommon at all to have lymph node dispersion. And so because of that information, the fact that similar to radical prostatectomy, where the PSA started going up again, prostate brachytherapy alone, seeds going up and PSA going up again, I started to use external beam radiations. At first, it was 3D conformal. It was kind of primitive by the IMRT standards, and then we continued to work our way up the ladder. We actually did DART, which is pinpoint accurate. But now I do treat these lymph nodes with the DART along with the prostate in select areas outside the prostate, and that's why we really push the envelope up to the 90 percentiles in terms of cure, long-term cure, and I've published extensively on them. The cure rates and successes and the diminished side effects associated with it. So it's it's a necessary. I wouldn't even consider now. Sometimes there's a case where you have to do brachytherapy alone, but more often than not, I would definitely recommend a combined regimen. And the other thing that we know is that hormones, which they're miserable, they cause all kinds of side effects, but they do have a big advantage because when you deliver radiation and the hormones simultaneously, you get a really big burst of the immune system. And everything that we're doing these days is looking at the immune system and ways to bolster it. And going back to nutritional supplements, that's another reason why the Mediterranean diet can help with the immune system. Select vitamins you may read about, like zinc, vitamin C, and the turmeric, and zinc, D3, and C would be the three main. There's another one called quercetin, which is interesting. It's being looked at. But anyhow, the immune system is spiked with hormones. It's spiked with radiation. Given together, it's a big spike. It's not equal to each of the parcels. It's not 1 + 1 equaling 2. It's 1 + 1 equaling 4 or 5. But we do try to come down in the duration of hormones. So I don't like giving hormones, and in some patients I don't use hormones at all. And I tell them we're not going to use hormones at all. It's not necessary. But with others, we do feel it's necessary. But when we do use it, it's many institutions now will be using 2 years or at least 18 months or 3 years. That's pretty hard, and sometimes it brings upon some permanent consequences. So we do just try to take advantage of it. And I've published my own data supporting that shorter durations of hormones are equal to longer durations. So, all right. Are there any other questions? I think we'll wrap it up, and thank you for coming.
Thank you.